Live. Hi, I'm Sonia Singha from WorkSafe Tasmania, and I will be your moderator today. This session is work oriented treatment, best practice strategies for mental health management in the workplace, presented by Darren Brendis from PeopleSense. In recognition of the deep history and culture of this island, we acknowledge Tasmanian Aboriginal people, the original and continuing custodians of the land, sea, and sky. We acknowledge and pay our respects to all Tasmanian Aboriginal people, all of whom have survived invasion and dispossession and continue to maintain their identity, culture, and Aboriginal rights. Please now take a moment to read the following slide about information received today. Please use the chat tab to type any questions you have for today's presenter. Those questions will be answered towards the end of the webinar. Only presenter webcams will be used. And today's presentation is also being recorded and will be available on the WorkSafe Tasmania's YouTube channel at the end of the month. It is now my pleasure to introduce our presenter, Darren Brendis from PeopleSense, Psychology and Wellbeing by Altius. Darren is the co-founding director of PeopleSense Psychology and Wellbeing by Altius and a registered psychologist with more than 30 years of experience. He has received awards for service excellence and has expertise in various areas of counseling, trauma treatment, coaching, and organizational psychology. Welcome so much, Darren, and over to you.
Thank you very much for that warm welcome, and welcome to everybody. Good morning, and hopefully you've got some great weather there. It's fantastic to be able to talk to you today about work-oriented treatment. This is something that is very close to my heart, having worked in this industry for a long period of time. Quick overview of the agenda. I'm going to just provide some background information, which I think most of you are probably familiar with respect to psychological claims and what the research tells us. And my understanding is that at the moment that Tasmania is experiencing an increase in the number of psychological claims that are becoming apparent. We'll talk about some modifiable factors, which I think is really important from an employer perspective or an organisational perspective, things you can actually look at before actually speaking then about work-oriented treatment and what actually work-oriented treatment means as opposed to what I would consider more mainstream psychological treatment. And then I'll give you some other organisational strategies around what can be done to minimise, because I want to try and put a real proactive focus on this session today. So I think there's always a lot of chat around post-claim, but what is it that you can do pre-claim or pre-injury or pre-illness, which is going to enable you to set your organisation up for success. So if we look at, and again, some of these statistics you might be seeing and familiar with, but I think we should remind ourselves that despite the fact that psychological injuries within the workers' compensation context are still relatively small, they are actually growing in frequency. And really importantly, I think you can see that the cost of psychological claims far outweigh those of a physical injury or disease. So the median around about $55,270 versus $13,883. So quite a significant difference there. Most are related to anxiety or stress-related disorders, around 36%, and 34% reaction to a workplace stressor or something that has occurred, for example, perhaps a critical incident. Again, if we look at the lost time with respect to psychological injuries, hugely outweighs physical injuries, 30.7 weeks versus 6.2 weeks. So despite the fact represented a small proportion of overall claims, they are much more expensive and duration-wise tend to go on for much longer. When we talk about mental health, I think, and specifically with respect to a workers' compensation context, it's really important that we consider the biopsychosocial model. We can't just treat the actual presentation in isolation. And when we talk about the biological or biopsychosocial model, we talk about three main spheres, one being your biological makeup, including genetic vulnerability, your overall physical health, propensity for disability, family. So it's in terms of social, we're talking about your family circumstances, your peer group, and what is going on in your social life. And from a psychological perspective, we talk about your self-esteem. What are the coping skills that you have developed? What are the social skills that the person has? And all of these things come together to include things like your temperament, your IQ, your family relationships, your relationships within your community, impacts with drugs, and how it impacts on you as a person. All of these things lead to a mental health presentation. And that's why they are far more complex than at times managing something of a physical nature. The other thing with a physical injury is you can generally scan it or see it on a scan or some measure, whereas with psychological injuries, it's much more difficult to actually measure it, and therefore there is always some skepticism, I feel, around the presentation of psychological injuries. If we look at the more common mental health conditions that we see within a workers' compensation context, these are generally dominated by anxiety conditions and mood conditions. But when we talk about mental health, we should acknowledge that mental health conditions affect how you think, how you feel, how that person behaves, and how they interact with other people. And when they get to their more severe end, that's when it starts to significantly impact upon those domains. It can really disrupt a person's ability to work, and it most certainly has a carry-on effect into their personal relationship. We see it become quite pervasive, where something that may occur at work and which may lead to some psychological impairment does certainly impact upon the family situation, social situation, and all of those factors that we just discussed prior. The important thing that I wanted to emphasize today is that mental health conditions are real. I think it's very important to acknowledge that they are real, but more importantly, they are very much treatable. And it's really important that we get the right treatment at the right time. And I'll talk a bit more specifically about that, particularly in the workers' compensation context. Generally, mental health conditions or mental illness is a general term that refers to a group of conditions. And these conditions include, like I said, anxiety disorders, which are generalized anxiety, mood conditions for your depression and mood-related disorders, substance abuse, psychotic conditions with your schizophrenia and schizoid personality, some of the eating conditions, and personality conditions like narcissism, antisocial personality disorder, and borderline personality disorder. You've also got a range of trauma-related conditions. We see these a lot in the workers' compensation context. For example, post-traumatic stress disorder following a traumatic incident, and acute stress reaction. The other one that we quite often see within the workers' compensation context is adjustment disorder, which is something which is, in my view, quite vague and nondescript. In terms of the propensity, approximately 1/3 of psychological injury claims are based on low morale rather than a substantive increase in mental health symptoms. And what we tend to see within the workers' compensation context is they become over-medicalised and they're given a diagnosis of this adjustment disorder. And I think, unfortunately, GPs, generally speaking, find themselves in an unenviable position where they're trying to cover off a lot of material. They have a lot of people coming through their practices. There's not really the time to spend with an individual to get down to the nitty-gritty of what is actually going on for them, perhaps in the workplace. And there's also, from time to time, the GP might have been a family doctor to that individual for 10, 15, 20 years, or generational family doctor. So quite often we see a situation which may be around a particular workplace issue, but it becomes medicalised into a workers' compensation related concern. Further to this, despite the health benefits of work, which has been put out by the Australian Faculty of Occupational and Environmental Medicine, their position statement, which really endorses great return to work practices. And I know a lot of OC physicians and doctors, insurers, and rehabilitation providers have all adhered to this document. Changes have been minimal. There's been rarely any changes coming out of that document. And when we talk about psychosocial issues, really importantly, there's things around perceived support. How much support am I getting, or what is the perception around that support? It is very subjective. It relates to the subjective experience of the individual. Is there supportive leadership within the organisation? Is it punitive, or is that leadership model more supportive around helping that person with a return to work? And quite often what we see within the workers, not only in terms of psychological claims within a workers' compensation context, but also physical claims, there tends to be a blame culture around, my employer's done this to me, and therefore, they need to take the blame, they need to pay me back, or I need to get something in response to that. And sometimes the whole system is set up around this blame culture, which is really unfortunate. If we also look at the kind of pervasive nature of your mental health status, it's interesting that the mental health presentation of an individual is the strongest predictor of disability in cases that go beyond 12 months. So that's for both physical and psychological. So in other words, if we were to assess that person's mental health presentation, that is a better predictor of disability post 12 months than the actual physical injury itself. And this is why I think as an organisation, you should be looking at what can we do as an organisation which prevents injuries in the very first instance, and think much more proactively around that space. Mental health is at least 2 times stronger predictor than the physical condition and pain. And I'm sure you're mostly familiar with this, but compensation schemes deliver worse health outcomes than non-compensation schemes. The recovery times are longer, more treatments involved, and it tends to be those restrictions or those ability to do things are restricted for longer periods of time. So let's look at some of the modifiable factors that one can do. And I'm talking about pre-claim here. First off the rank is poor leadership. And unfortunately, what we tend to see happen within organisations is that people are promoted on the basis of their technical expertise. So they'll be very good at a job, and then they get a promotion on the back of being able to do their job very, very well. What happens, though, is the role changes significantly, going from a technical role of being able to do the job to a people management role. And quite often, our leaders and our new managers are not equipped with really good people management skills. And this is where we get into some tricky water. And what we should be doing as an organisation is investing in our leaders in our new leaders in particular and our managers, and building their capability as people managers, making them better people managers. And this will have a direct impact upon the propensity for people to go away, go and see a doctor and file a claim, not only for psychological claims, but also for physical claims. But we tend to be way too reactive. We spend a lot of money on post-claim issues instead of thinking more about a pre-claim and developing your leadership cohort as best as possible. Ideally, you would have a dedicated return to work coordinator within your organisation. This is someone who's very familiar with the workers' comp scheme, is very familiar with the demands around return to work, what good return to work looks like. And they, again, have been trained specifically in this particular area so that in the event something were to occur, you've got someone who can really navigate the system very, very well, who knows what best practice looks like, and is able to support those individuals who are injured, as opposed to quite often we see this role fall to someone within HR or even an office admin role or someone within safety who's really perhaps not got the experience nor the desire to perhaps work in this return to work coordinator space. And it is quite a specialised role, and I strongly encourage you to invest in getting someone internally or externally to be able to help you with that. I think it's really important annually to look at your workplace culture, to consider what is going on within our organisation, get a snapshot and a feel around where are we at? Do people or are people engaged? You know, are they coming here and enjoy coming here? Have we got any hotspots within our organisations? Are there certain departments where there's lots of conflict, lots of disruption, poor performance, high turnover of staff? There's a whole range of variables that you can assess via lots of different reporting mechanisms or survey mechanisms to assess where your workplace culture is. And I think this is becoming more relevant now with psychosocial risk becoming important, where it is imperative that you are looking at your organisation, determining where those risks are, and then putting in place a course of action in terms of actually ameliorating what those risks are. Create a supportive reporting culture so that if things are going on within your organisation, you should know about it. Quite often we hear, I get involved in organisations where there is a lot of talk about a particular manager who a lot of people say, oh, that's just Bob, that's just how he behaves. And, we kind of, give him, free rein because, he's been with the organisation for a long time. I think, the modern workplace, we've moved beyond that kind of attitude. We've got to create a culture where people can report hazards, can report concerns without fear that they are going to be penalised or restricted in terms of their ongoing employment or career development. Otherwise, what happens is things get pushed under the carpet, and I think it's almost the acceptance of bad behaviour within a workplace, and we really should be trying to eradicate that wherever possible, because again, if we're talking pre-claim or proactive strategies, we want to remove all those things that are going to create problems for us downstream. If someone is injured and off work, then make sure you maintain, this goes back to having a good return to work coordinator, early contact with that individual. Make sure there's regular contact, reaching out, checking in, see how best you can support that individual, and in keeping in mind all the time having a return to work focus. And it may not necessarily be that you're talking about return to work when you're reaching out, but there's very much the emphasis on, we're really looking forward to getting you back. What do we need to do to help you engage with us? And doing that as early and consistently as possible, as opposed to just allowing that individual to fall off the radar, and then 3 months later you go, oh, I haven't reached out to Jane. I've been getting these medical certificates, but no one's really been in contact. I think about it, the perception from the injured party's perspective. What would they be feeling? Quite often, when I meet with people, I go, well, I haven't heard from my employer for 2 months. What kind of perception and meaning does that send to that particular individual? Is it about a caring, supportive, engaging environment, or an environment who really doesn't actually care where they are or what's actually going on? Further to this, I think it's really important, again, what we see a lot is there is simmering conflict in workplaces, which then move on and progress into full-blown claims of a psychological nature. It's imperative that you address conflict as early as possible in the workplace. Now, most of us don't like conflict. We don't like dealing with conflict. And the tendency is to just ignore it. Hopefully it'll go away. And we do this not only in the work context, but also as a psychologist, I see it in a family or outside of work, where there's kind of, if I ignore it for long enough, perhaps it'll go away. But what we tend to see is a festering within the workplace, and it amplifies. It gets bigger and bigger and bigger. And quite often what could be something which is relatively minor and even petty to a certain extent becomes really amplified and blown out of all proportions. So I strongly encourage you to address conflict sensibly. If you're nervous about it, get someone in, a consultant who's a trained mediator, who's very familiar with being able to manage conflict effectively, and so that you can get individuals back on track as early as possible. The other thing I think is that avoid unnecessary disagreements or disputes as early as possible and as soon as possible. Now, the way to do this, again, links a little bit into that managing conflict, but it's being transparent with information, being very clear with information, being very clear around what your role is as a worker, what my role is as a psychologist, what your role is as a GP, and what your role is as an employer. So everybody is very, very clear at the outset who does what and who's responsible for what is the reporting mechanism, how often are you going to be in contact with one another. And again, this eliminates any opportunity for lack of information, lack of clarity of information, making sure everybody in this sphere is on the same page. So these are all things that can be done very, very easily pre-claim. If we look at post-claim, some of the modifiable factors, which I'll go into a bit more detail, but mental health treatment capability. Quite often we see psychologists engage in practices where there's ongoing treatment ad nauseum without any significant changes in the presentation. And unfortunately, I see this in schemes where people have been seen for over 100 sessions with a psychologist. Now, at some point, it is important for a treatment provider to go, I don't think I'm making any difference here. I don't think I'm benefiting you. Perhaps we need to look at another opportunity. Over-medicalising workplace issues. I mentioned this a little earlier. Again, I think the job of a GP is very, very hard, but quite often these issues which could be resolved, i.e. conflict, become over-medicalised and get into the workers' compensation system when they should be kept out of the workers' compensation system. It's important that you look at your psychosocial factors at an organisational level. What is happening at your organisational level from your claim data that you can start to make some changes? Is it about leadership capability? Is it about unclear process? Is it about role clarity? Is it about how conflict is managed? looking very, very carefully at that claim data so you can start to design appropriate intervention based on what's actually happening within your organisation. Siloed treatment is a big issue, and that's why I mentioned getting everybody on the same page, is where you get practitioners who are really operating in silos. They think they're doing the right thing by the injured person, but they're operating in silos and not really communicating with GP or employer or psychologist or psychiatrist. So there's a lack of that collaboration around how do we best assist that person, and we tend to stick to our silos and what we're really, really comfortable with. The other thing that I see quite often, certainly within the psychological context, but I see this with a lot of other allied health practitioners, is that at times their role as a treater becomes very blurred and we become advocates for the injured worker. And this is really dangerous territory to get in, because you start to lose perspective. It's not the role of a psychologist or a physiotherapist or a podiatrist or whatever it might be, OT, to be advocating on behalf of the injured worker. By all means, help them develop the skills to advocate for themselves, but it is not the role of that person to be advocating. And so when you see this early on, that you've got a treatment provider advocating, you know it's going to be challenging, and that behaviour needs to be challenged. And really the crux of what I'll talk about in terms of work-oriented treatment is that where you see a return to work being mutually exclusive to treatment, rather than being the primary objective of treatment. The primary objective of treatment within the workers' compensation scheme is getting you back to work, getting you back to work as quickly and as safely as possible. It's a workers' compensation scheme, and we need to acknowledge that. It's not an ongoing social security system. Okay, so the focus really needs to be on return to work from all parties. So if we look at some of the best practice strategies, ideally working with GPs who ideally have a qualification in workers' compensation, or at the very least an interest in occupational medicine. And I think from time to time, I've worked with GPs who say to me, Darren, look, I hate workers' comp. I hate the reporting. I hate all the conflict. And, I really don't like it. And I always come back and say, well, you don't need to do it. You're not obliged. No one's forcing you to do it. It's really your choice to engage with that. So I think ideally finding doctors who have an interest or some training in occupational medicine is really, really valuable. Obviously, work-oriented treatment rather than pure psychology treatment, again, is imperative in terms of aiding recovery, and I'll go into that shortly. I've mentioned timely and accurate reporting. It's really, really important, particularly around the psychological claims space, because quite often what we see is once a claim's made, the history might go back 3 or 4 months where things were actually occurring. If you invoke a really early, timely, supportive reporting process, you don't have that time elapse between when something started within the workplace and actually putting a claim in. I think it's very, very important that employers and all parties demonstrate genuine empathy and concern for the individual and worker. It's really important to take the time to understand their perspective, to actually see the world through their eyes so that you can understand the meaning behind what's actually going on, which will enable you to ensure that you can help that person as best as possible. Have everybody cooperate and develop a return to work plan. get everybody involved in that process again, so it's very clear, it's very transparent, who is doing what and when, who's responsible, what are the check-in points, so that there is no ambiguity at all whatsoever around a return to work program. Further to this, make sure that you provide meaningful, suitable duties if you are fortunate enough to be able to support someone with a return to work program on suitable duties. Don't get them sweeping the floor or other mundane, menial task, which is really demeaning. It doesn't create a sense of supportive return to work. So be sensible about what suitable duties you have got and can put into a return to work program. And along with this, create cooperation. I continually am surprised by, at times, the lack of cooperation amongst leaders within organisations and getting on the same page with respect to return to work practices or enabling an individual to get back. It's really important that everybody is driving and singing from the same song sheet. You need to actually get onto the same page for everybody's benefit. And create a culture within your organisation of managed, supported, and early return to work for all staff. Now, I've included all staff in there because I think there's a great opportunity for organisations to complete this for not only compensable injuries, but let's say someone has suffered a sporting injury or is recovering from a significant illness and needs to come back on a graduated return to work program, perhaps with some modifications. Complete that, bring that into the picture so that what you create within your organisation is a culture around, we're going to help you get back to work, irrespective of whether it's a compensable claim or a non-compensable claim or an injury and illness. We really want to help you get back to work. And over time, you can create this culture around early return to work and a supported return to work. Okay, so I want to talk to you about work-oriented treatment. Again, this is the crux of the presentation today. Work-oriented treatment includes discussions around return to work and is characterised by specific functional goals. That is, if someone comes to see me and we're working on perhaps an anxiety reaction, then I will be giving them homework to do on a daily basis or a weekly basis. This could include, you need to go for a walk around the block every day for 5 minutes or 10 minutes. I want you to drive your car for a certain time. I want you to go to a supermarket and walk within the supermarket. There are specific functional goals that the person needs to adhere to as part of the treatment plan. It's not just ending the session, thanks very much, I'll see you next week. So there's homework assigned. There is always the opportunity to utilise motivational interviewing. And what I mean by that is enabling the person to move through those stages of change to avoid them becoming stuck, or if they are stuck, knowing that they can't stay stuck. So utilising motivational interviewing and the stages of change model in order to move people from that, what we call pre-contemplation to contemplation to plan and then to action. So at all times you're using that motivational interviewing model, which is regularly used within addictions, but more importantly can be used within the workers' compensation context as well. One of the things that is really frustrating from my perspective when I review cases for insurers is that psychologists providing copious amounts of sessions without any measures being employed. No measures to determine, is the person getting better? How do you know the person's getting better? So there should be regular outcomes measured. It can be as simple as the DASS-21, the Depression, Anxiety, Stress Scale, and the WHO-5 World Health Organization Wellbeing Index, could be the Erebro. But there should be regular monthly assessment and measuring of the individual's progress, so that can be tracked over time, so you can see symptom reduction, so that you know the treatment, you know what you are doing is working for the particular client. And it's also really enforcing for the client to see that they are gaining. They're actually moving ahead as well. There should be always homework given in terms of work-oriented treatment. If homework is not being given to the individual, it's not work-oriented treatment. Therapy occurs not just within the counselling room, it occurs outside of the counselling room. And there's great opportunities outside of the counselling room for individuals to practice the skills that they may have learned with that particular psychologist. So there should always be homework. If you're talking to an injured worker, ask them, have you been given homework? Are you doing something? Build active treatment strategies. Again, this is about getting the person moving. Build skills for future scaffolding. Help them with assertiveness. Help them to be able to advocate for themselves. Park wherever possible pre-existing issues. So, for example, if there is pre-existing issues with another employer which may have occurred, they need to be parked for a period of time. I think it's really important that you are transparent about the entitlements within the workers' compensation scheme that you are working, and return to work is the focus right from the initial assessment. You are here for treatment, and as part of that treatment, we will be focusing on how do we get you back to work, and help them with adult problem solving. Quite often, Alice said, you get into that advocacy mode, or you get into some conversations around, I really, want to get my employer back. Look at what they've done to me. It's about engaging with that client on an adult level, so there can be some adult problem solving taking place. I'm going to skip that, Clyde. What non-work oriented treatment is advocacy is not independent treatment. Being adversarial and towards the employer. So where you've got a treatment provider who is adversarial toward the employment and leading to blame is not work-oriented treatment. Having a treatment provider who is not clear on the parameters, the restrictions, the requirements of the workers' compensation process, an ongoing reliance on the psychologist with excessive sessions, and unfortunately, I'd rather cynically put in there, but I think it is a reality that quite often treatment providers see it as a cash cow and continue to treat on an ongoing basis when there's just no need in order to do that. Lack of collaboration with other stakeholders. Treatment providers should be willing to collaborate with all of the key stakeholders within the realms of where the parameters of what they're working. And non-work oriented treatment is again defined by those long absences from the workplace. It is very much engaging in a return to work process. So saying to someone you need 6 months off work is not work oriented treatment at all. I wanted to just talk briefly about some innovative approaches which I think you can really assist your organisations with. First of all, if you have an EAP program in place, are they measuring clinical outcomes? Are they measuring the success of that particular program? Because I think having a really good evidence-based EAP program can resolve a lot of issues prior to them becoming compensable. So you can resolve them as quickly as possible. As part of that EAP program, it's a great idea to have a manager assist program whereby a manager can engage with a psychologist to discuss a clinical issue, or alternatively with an organisational psychologist to discuss an organisational issue, for example, conflict, with someone and seek some advice and support in order to how best that manage that situation in order to prevent those things occurring. Again, this should form part of your EAP program. If you're not getting that, start to explore options and opportunities, because again, this is a very great opportunity for organisations to get into that pre-claim space. Consider health coaching. In the United States, we're seeing in North America a lot more health coaching within organisations, whereby it's actually working with individuals to improve their health. And this can form part of your overall wellbeing strategy. And I'll drop that down to the next point, proactive wellbeing checks. If you are an organisation where your staff are potentially being exposed to vicarious trauma, think about doing some proactive wellbeing checks, monitor their wellbeing, enable them to develop some strategies around their wellbeing, which might be relationship related, exercise related, nutrition related, financially related, any of those pillars of wellbeing, getting them to work around those things in a proactive manner. We've got a great program which we call Mind Movement, but essentially that is the combination of working with a psychologist and an exercise physiologist, because we know that exercise has a very positive impact upon one's psychological presentation, similar to that of low-dose antidepressant medication. So you can lift mood and reduce anxiety by regular exercise, gym-based, resistance-based training, and getting an EP on board to combine with psychological treatment is absolutely a fantastic way to engage in helping people get back on track and get back on to work quickly as possible. Finally, just in terms of innovative approaches, I think quite often what we see from the EAP perspective is critical incidents can be managed very, very poorly and can lead to claims. If you have a critical incident, make sure that individuals involved in that incident are getting psychological education so that we can normalise people's reactions. There's targeted screening of those individuals to ensure that they are checked in on, and follow up with those individuals to ensure again that they are getting that they are being monitored in terms of their well-being. If they're demonstrating any trauma-like symptoms, that they are treated as quickly and as timely as possible, so they're not just let go again to wander and then 3 months later they submit a claim because they're experiencing some trauma-related concerns. This is just an example of some wellbeing checks that you can do around nutrition, exercise, finance, and legal that I mentioned. Great opportunities for you to engage in that proactive wellbeing space. I'll move on there. I've mentioned the critical incident is being really important in terms of work-oriented treatment. If you've got someone doing group debriefing, that is no longer clinically indicated because there is a potential to re-traumatise clients. Focus on normalising reactions, providing psychoeducation, and encouraging engagement with support networks. It's always good, as I said, we measure everything that we do, impact of event scale, DAS21. It enables you to assess where is the individual at and track that over a period of time. You need to risk assess. So for if those individuals who are being severely impacted, they need to be able to be supported as quickly and efficiently as possible, considering both ethical and legal requirements, particularly around the fact that if there may have been a fatality involved. I think it's really important that follow-up is provided to those individual clients according to their particular needs. It's not a one-size-fits-all model. It's very tailored intervention. And monitor those clients and carefully consider any significant predisposing factors which may impact. So have they been through or have they experienced adverse childhood experiences, as an example, which we're seeing a lot of research coming out in that particular space, and provide support and advice to workplaces in a consultative way in how best to manage those situations. I mentioned the wellbeing checks, and just really quickly talking a little bit about those. It is designed around providing self-care strategies. It's not there to provide therapy. It's about self-reflection and helping the person develop self-care strategies. It's certainly great for people who are early in their career, establishing a safety plan for their well-being. And it's an opportunity for those people who are working perhaps in child protection or in prisons department, those sorts of jobs where you can actually start to enable them to learn about early warning signs of distress. And the psychologist can identify any significant issues around depression or anxiety, which the individual may not be aware of, and then connect them into appropriate support. Again, this is a proactive opportunity for individuals to be supported. I'll skip that. I just want to quickly mention health coaching. This is a great opportunity for you to adopt as part of your overall wellbeing strategy internally. It involves a partnership with a coach to guide, empower, and motivate the recipient to change their behaviour. It differs from traditional approaches where the recipient is provided with information and instructed to do things, and the clinician decides best. It's really important to enable the individual to identify what is important for them. What do I want to get out of this? What do I need to do this? And so that they can get the support and go and seek that support and educate themselves to achieve that. And it's really what you're trying to do is enable those individuals to thrive. This is a really quick example of what it might look like. There might be some health screening, DAS 21, WHO5. Again, you see the theme of measuring everything so you can measure outcomes, discussion of coaching goals, 3 to 4 focus areas, and it could be around parenting, relationships, children's support, nutrition, exercise, financial support. And that is what's really imperative. And generally speaking, I would run it for around 12 weeks as part of the program. Resources, there's a whole range of apps that you can access. I won't go into huge details, but there is a lot of apps that are you can use. We use our LTS Life app so people can track their activity. They can set up reminders. They can set up work challenges within the workplace, and everything is at hand to be able to support their coaching journey. I did mention the Mind Movement program. I just wanted to share with you what we generally do within that program. There is a lot of psychoeducation, and we feel that this is really important. Quite often, people's mental health literacy is very, very low. They don't know or nor recognise signs and symptoms of psychological health. So a lot of it is around psychoeducation, and we use CBT for that to challenge some of those unhelpful thinking. And a lot of it is about behavioural activation. We want to get people up off the couch, off the bed, and get them moving. That is the idea. We want to increase functioning at all times. And that's where the role of a good exercise physiologist to practice movement in a safe, supportive environment is absolutely a fantastic opportunity. It enables the client to build their confidence and their self-esteem, and you can set goals to help them overcome those obstacles which might be preventing them from being able to get back to work. It can help things with mood and certainly with sleep, because quite often we hear, I'm not sleeping anymore, or you're not exercising, you're not doing anything, you're laying around, therefore your body doesn't need as much sleep. So the more you get moving, the more tired you become, it improves your sleep outcomes as well. It can also be designed to improve on those interpersonal communication skills via the psychological therapy, which might be occurring in the workplace. So again, developing that scaffolding. We want to develop scaffolding around people so that if they do encounter issues in the future, they can actually manage it and they can retake control of their life. Again, these are some great stats that we've shown from the depression, anxiety, stress scale for depression pre-program, post-program. So you can see a reduction in symptoms, similar for anxiety, and similar for WHO5, their wellbeing scores going up to clinically significant levels. So this really does work, and I think it's a great opportunity that you could potentially use. That's just some more data, which I'm happy to share with you, but I won't go into you now. I mentioned some apps. I just wanted to share with you, these are some apps you can use: Mental Health Online, MindSpot, This Way Up, Smiling Minds Headspace, PTSD Coach. There's a Department of Veterans Affairs version, and Clarity CBT Thought Diary. There is a lot of different apps, treatment apps that you can use. That's just a handful that we use from time to time that you can have a look at and check out for yourself. Great. I've loaded you with lots and lots of information there in the time permitting. Really, really happy to answer any questions that you may have at the moment. I can see one there. My understanding is the worker chooses their own GP psychologist. What if they are not collaborative? Where does the employer stand? Great question. And again, I think this is really, really challenging. So I would go back to education. Very, very important via a return to work coordinator or really good rehab provider to educate those individuals around this is best practice within a workers' compensation context. Give them the handbook on the health benefits of good work. It's our role really as health practitioners to educate as much as possible. So quite often, if they're unwilling, educate them around what are the parameters of workers' compensation, what are the limitations of that, what does best practice look like, and appropriately challenge GPs and other individuals, other treatment providers around that. Engaging a consultant who can help you with that and do that on your behalf is also really, really useful. But I would start with education in the first instance before moving into anything else at that particular time and see how that goes.
We've got another question here, Darren. It says, to what extent does the shortage of available psychologists impact the duration of a claim, and how can workplaces and return to work coordinators support injured workers whilst they're waiting for their initial appointments?
Yeah, I understand. Look, the reality is within Australia, there's a shortage of psychologists with just in order to be able to provide treatment. What's more, a lot of them actually aren't doing workers' comp, which is, ideally what we want to do is work-oriented treatment. So doing your homework to find a practitioner who is able to engage in work-oriented treatment. And even if the injured party wants to wait for their GP to make a referral, or there's a wait time to get to that person, perhaps saying, look, we've got this psychologist, in Launceston. If you're based up there, obviously, we know they could see you next week. Why don't you go and see them as a starting point until you actually are able to engage with your own psychologist at a doctor's recommendation? The other point that I would make to that is that telehealth is very, very effective. So it is equally as effective as face-to-face sessions for telephone and or video sessions. So don't be afraid to explore other psychologists who may have availability, but they may be on the mainland.
Thank you, Darren. And there's another one here which says, could you please advise on how to access return to work coordinator training?
So there are a range of organisations, and LTS is one of them, but I'm not here to advertise our services, but there are a range of organisations who actually provide return to work coordinator training. And in fact, it's quite possible that WorkSafe Tassie actually may in fact do that internally. But I think if you started by Googling, you could probably find training around that, and you can either tailor training according to your specific needs of an organisation if you've got a cohort that you want to train, or alternatively, if you've got one individual you want to train, then by all means just Google, and there's generally a lot of different training providers out there who are able to assist with that for you.
Lovely. Thank you, Darren. We might take another couple. There's one which says, after a critical incident, is it practical to ensure that workers attend a mandatory EAP session?
Really, really good question. So my advice would be those individuals who are involved within the incident or management of the incident, I would do get them together, and what we do is a psychoeducation session. Now, it's very different from the traditional debrief model that was employed when I first started my career. We would get everyone in a room and get them talking about the incident. And we used a particular model, the Mitchell-Everly model. It's now been found to be clinically not indicated to do that. What you do is you get everybody together who've been involved in the incident, and you talk to them about, these are some common reactions that people experience post an incident like this. It doesn't necessarily mean that you will experience them, but if you are experiencing them, then that is okay. And so you're actually talking about the common reactions from a thinking perspective, from a behavioural perspective, and then you talk about what you can do about that in order to manage that. And then what I would be recommending is that then you would be targeting those individuals who were intimately involved in the incident. So those people who may have provided first aid, those people who might have called the ambulance, or those people who may have assisted in some capacity, I would be checking in with them one-on-one. And again, impact of event scale or a DAS or a WHO5, measuring where they're at, and just tracking them over a couple of weeks to determine where they're at, and providing appropriate psychoeducation and support for those individuals. Moving beyond that, if you have people who are have experienced trauma, there are two treatments that should be provided. One is eye movement desensitization and reprocessing, EMDR, and the second is trauma-focused CBT. They are the gold standard for post-trauma reactions. If you have a psychologist employing something else, then I would challenge that, because it's not clinically indicated and it's not best practice.
Thank you, Darren. I think there's another one which says, does personal stress that is occurring for the worker impact on their claim for work-related stress? For example, if they don't have that personal stress, it wouldn't have resulted in a work-related stress leading to a claim, which is accumulative effect.
Correct. And this is where it gets very, very tricky, and why, unfortunately, that can't be excluded, because go back to my original slide around biopsychosocial. You're taking the person as they are, and we all have those life stresses, and within our lives outside of the work situation. Unfortunately, there can be things that occur within work which can escalate that, and you will find that we do see that a lot within the workers' compensation scheme, where there are other issues at play. It's best if you can park those issues, as long as they're not impacting too much. This becomes quite difficult though with trauma, where there's previous trauma history and those trauma connections come into play. And I don't want to get too clinical right now, but it does become quite challenging. But focus on the work-related issue, and focus on how best do we help you recover from that work-related issue.
Lovely. Thank you so much, Darren. I think we've got one last question. I reckon it's one of the most important ones. It says, are these presentation slides going to be shared?
I'm very happy to share them. I've got no real issue. For me, the more educated we become around what is best practice and how best to help organisations and their individuals, very, very happy to share them. Just don't
Perfect.
reproduce them is what I would request, though. Thank you.
Well, thank you so much, Darren. I think that was a wonderful session, and I think that has been echoed in a lot of feedback that we've received from our attendees here. This also brings us towards to the end. This event obviously has been run as part of the WorkSafe Tasmania month, so please head to the worksafe.tas.gov.au/month to find out more of the webinars and in-person sessions that we have upcoming. There will be a survey link towards the end of this session, everyone. We'd love to hear your feedback. And it has been an absolute pleasure to have you, Darren. We've attained some wonderful pieces of knowledge that we can take home and apply that to our workplaces. Thank you again. Thank you everyone for attending today's webinar. Have a great rest of the day and just stay safe, everyone.
Thank you.